questions, you can wave your hand in the air and someone will come around and collect a piece of paper. We'll just try to take, we'll get through as many as we can. And you can send more up if you need to. I guess we can, should we?
So my name is Christopher Hess. I'm one of the movement disorders neurologists at the center, and I'm also a movement disorders neurologist at the VA in Gainesville. So if any of you have capability to be seen over there, that's always a possibility as well. So we'll go ahead and get started. So the first question, Rasagiline is known to decrease off time. If dose still 1 milligram a day, is there any indication for going higher than 1 milligram a day? So Azilect or Rasagiline, the dose is 1 milligram a day. The problem with going higher on the dose is as soon as you go above 1 milligram a day, the medication, which is an MAO-B or monoamine oxidase B inhibitor, loses its specificity for the B receptor. It becomes a general MAO inhibitor, and it can actually be dangerous and interact with other medications. So in general, there should never be an indication to go above 1 milligram a day for Rasagiline.
I'm Irene Malati. I'm also one of the movement disorder neurologists. One question is caffeine good or bad? Is coffee or caffeine good or bad? So if you ask anyone on this panel, we'll say it's fantastic because we drink it every morning. But with regard to Parkinson's disease, it's been shown that an interesting epidemiological thing, which means when they look at risk factors and when they look at people with Parkinson's and say what could have made them more likely or less likely to get it, it turns out that coffee drinkers have a slightly less risk of Parkinson's than non-coffee drinkers. But it's not the case that if you have Parkinson's and you drink a whole bunch of coffee, it's gonna make you better. And we don't know what that link is. It's actually been studied. An interesting study looked at what about tea drinking? Is it the coffee or is it the caffeine? And it turned out that the tea also, the caffeine content, an equivalent caffeine content was also good at appeared to be lowering the risk. And so nobody can explain if that's because other things that make you at risk of Parkinson's happen in people that aren't in a lifestyle drinking coffee, or is it the caffeine? We don't know, but it does appear to lower the risk.
I'll add basically to this. So I'm Dr. McFarlane also. So caffeine has action on a receptor in your brain called the adenosine receptor 2. So, and that's in the part of the brain that's affected by your Parkinson's disease. So there's plenty of research on caffeine. I will tell you that the research I know that's been done on this in animals tends to suggest that it affects a little bit better in men than women, and we all know that men and women are different. But caffeine is good, but we're not recommending drinking a pot of coffee a day, though.
And interestingly, they've even been studying a number of drugs that work on that particular receptor in the brain because of seeing that relationship with caffeine. So far, in the small studies, they look promising, and then in the big studies, they haven't panned out, but it's still a possible target that's been looked at.
So we have one, I'll combine one. So we have one question on young onset Parkinson's disease versus older age Parkinson's disease. I think we do all up here feel that when young onset patients present, there are different challenges than when elderly folks. There is no one age. I mean, I guess we could say 65, 70 and above or below, but there is no one age. On average, onset of Parkinson's ranges. We see patients from age 30 to 80 years old or older develop Parkinson's disease. Young onset patients present challenges in the sense that they're going to have Parkinson's disease for a much longer period of time. We may want to look into perhaps genetic or familial factors that are related to young onset Parkinson's disease as well. We have to think about sort of the types of drugs and treatments. You're going to be on these drugs for a much longer period of time. I think we had good talks today about the different drugs that are out there. For instance, the carbidopa, levodopa, the dopamine agonists. Which one to start? And that's a different question when we talk about patients who are a bit older. I think those of you who are probably in that older range, I think drugs, people tend to be more sensitive to the drugs and their side effects. And so sometimes less is more, and we aim for drugs that are a little bit better tolerated, like the carbidopa levodopa over-agonists. But that's not a hard and fast rule. Okay, nothing in treating Parkinson's disease is ever black and white. We have the 50 Shades of Grey. No puns intended, but definitely there are definitely differences. The other question that was asked as part of it: do you progress faster when you're older versus young? Well, that's a hard question to answer necessarily. It's true that there are more complications if you're older. You have more health issues often that goes along with it, and of course, lifespan is shorter. You're older. So there are two things that play a role, but I would say yes, there are more challenges when you're older, but there are also different challenges for young onset Parkinson's. I hope that answers the questions. Yeah. I'm not sure that we have seen that yet, but that's a really good point in terms of environmental factors. We might see that yet, but we need more epidemiology to study, the onset of Parkinson's in the young versus older ages. That's a good point.
All right, so I have a question here, which is a very good question. It says, we are encouraged to drink lots of water. But if the substantia nigra accumulates water, what do we do? Well, I'm drinking water. I strongly suggest that you keep drinking water. There is no relation between the amount of water you take and the measurements that are occurring on the MRIs. They're completely separate and unrelated. So you should definitely not stop drinking water. You should continue drinking water. Okay. It's a very, very good question. I did not expect.
Also another good one. My spouse has PD and is afraid of falling, is very stiff, and doesn't have bad tremors, which we know can be the case. You don't have to have tremors to have Parkinson's. My spouse hates exercise and frequently refuses to do it. I want to bring him to PT and want to get a personal trainer involved to force my spouse to do more exercise. What do I do? I sympathize with you. I'd say about 50 to 60% of the patients tell me they hate exercise. Encourage your spouse to give me one visit. One visit for me to show you that exercise doesn't mean I'm going to sign you up to run a marathon. It means I'm going to show you a way to make your body move better, to decrease the stiffness. That is a very easy one. On that first session, we can put you down on the mat, take you through a bunch of stretches, and I guarantee you your spouse will feel better after they leave and we've done 5 minutes of stretching. So just bring them to the door and I'll take care of the rest. And we will help find so if you don't want to call it exercise, we'll call it activity that will help modify the Parkinson's, and we will find something that we can convince your spouse to do.
The question I received is, what would prevent the pump being like an insulin pump if used subcutaneously and absorbed into the blood, and therefore being less invasive, smaller and able to read in greater than 16 hours? Actually, the company is looking at having a smaller pump. I've actually been part of the group looking at having one because we've complained that this is a very cumbersome pump and stuff to use. I don't know anything about it being subcutaneously because the tube has to be in the ligament of tripes where the gel is absorbed, and that is where cinnamon is absorbed. In terms of the 16 hours, that is because the cassette that holds the drug starts breaking down, and there's a byproduct of hydrazine, so you do not want that to be breaking down and going through your system. So we have lots of different things that we're trying to work out, but we are working on a smaller pump, and we are working on a more concentrated suspension that can go for longer than 16 hours. But right now, this is what the FDA approved, and so we can't do anything until we can move on to the next level. Thank you.
So there was a question on what our thoughts are on focused ultrasound. So in the past few years, there has been some research done on non-invasive mechanisms of making a lesion in the brain similar to the BBS that we do now, which is actually an electrode that's placed in the brain. The most important thing to realize with the focused ultrasound is that this is a destructive lesion, even though it doesn't involve opening the skull in the same way that a surgery does. And once this procedure is done, obviously it's very important that they have to get it in the right place, and that process has not been as well established and carefully carried out as it is for deep brain stimulation. And it can't be taken back. With your DBS, adjustments can be made, stimulation can be increased, decreased. Once the focused lesion is made with ultrasound, it's there and it can't be taken back. So it tends to be an option in some cases for some people who otherwise can't undergo DBS, but there's certainly no reason to think that it's in any way better than the standard deep brain stimulation.
Okay, this question says, how do you know if you're over-medicated with non-Parkinson drugs like sleep aids, antidepressants, anti-anxiety, etc., or am I just spacey from my Parkinson meds and my Parkinson's disease? So the question is, if you feel kind of spacey or dazed, how do you know what causes that? And basically, you kind of have to work with your treating practitioner to sort it out. It's true that Parkinson's can cause people to feel cloudy sometimes or fatigued. It also has an increased risk of sleep disorders. So sometimes disordered sleep causes, even though you spend the right amount of hours in bed, you may not be getting restful sleep. So there can be an excessive somnolence or sleepiness during the day. So looking into whether you could have a sleep disorder is number one. Number two is looking into whether there is a medication that's giving you side effects. All the medicines that treat, for instance, medicines that treat bladder problems that many people who have Parkinson's also may have, medicines that treat all these other things can cause sleepiness. And the best thing is look at the timeline when you first noticed it. Was a new medicine introduced? If not, you might have to work with your doc about stopping one at a time to see if that one of them makes a difference. But fatigue is probably one of the most common and challenging symptoms in Parkinson's, and it is very complicated. The question also included, how do I know it's not the Parkinson medication? And the biggest clue would be if the timing lines up. If you said, boy, half an hour after my pill, I feel really, really tired, then you might suggest there's a relationship. But it's always finding the balance between taking enough to control your symptoms and not overshooting.
I have a number of questions here about, well, I'm just going to lump them together basically about what is it, how do I know if I have something other than Parkinson's disease? So today we're focusing on Parkinson's disease in the symposium, and this is probably a longer talk. I won't spend a long time to answer it, but I will say I run an atypical Parkinson's or Parkinson's Plus clinic in the center, and there are a number of different disorders that mimic Parkinson's disease or look like Parkinson's disease. So it's not uncommon. Parkinson's disease tends to be the common thing that we see. There's nearly 1.5 million patients just in the United States who likely suffer from Parkinson's disease right now. Atypical Parkinson's disorders are much less frequent, of course, but they are very, they're quite devastating, just like Parkinson's disease. So what can you do? I would suggest really there are sometimes red flags. For instance, I have Parkinson's, my drugs aren't really working, or they never really work. Generally speaking, about 25–30% of Parkinson's patients don't really get a great response. But it is definitely something that if the medicines aren't working or never did work, that's what I would call a red flag. If you've never had tremor, that's not a really, I think there's probably many of you who have Parkinson's disease and tremor is not really part of your disease. And I think you heard Dr. Joe Jankovic this morning talk about there are subtypes to Parkinson's disease. There is one type that we see as mostly postural instability, gait problems, where tremor is really not a predominant part of the disease. But if you've never had tremor, you have more symmetric symptoms, or perhaps very asymmetric symptoms. That seems unusual. Or if your doctor or neurologist says, look, my tremor, it's not the typical pill-rolling tremor that, my fellow Parkinson's, or you see other folks in the room, they have something different. There are certain red flags that may bring up the possibility that maybe I'm suffering from one of those diseases that may mimic Parkinson's disease. It's really our job as your neurologist to kind of think about these things and keep a broad perspective. In fact, actually, our Parkinson's disease guidelines suggest that almost on a yearly basis that we as physicians kind of rethink things and make sure we keep an open mind about what's going on. So what are the possibilities? There are many drugs that you can take that can cause Parkinson's symptoms. I can give you a long list of different drugs. If you're on the psychiatric medication, antipsychotics can cause Parkinson's. There are a number of drugs like anti-nausea medicines. If you take those, it can cause potentially what looks like Parkinson's disease. Stroke, vascular disease can cause symptoms like Parkinson's disease. And sometimes can be treated just like Parkinson's, but it's not Parkinson's disease. It's called vascular Parkinson's. And then there are a number of other more rare disorders that we see regularly in the clinic, things like progressive supranuclear palsy, multi-system atrophy, Lewy body dementia, or cortical basal. I probably would spend an hour or even longer talking about each one of these individually, but just know that we look for these when we examine our patients, and there are specific issues and problems. Generally, these patients do progress maybe a little bit faster, they have more complications, and they really require a comprehensive clinic. I think that we have that. We have some really great support groups in our clinic, from the top down, really, that can really help you. And if you think that you've got some red flags or there's something's not working for you, by all means ask, and we will go and look more carefully and see whether we can do. There are things that we can do to help patients for all of these disorders.
The next question that I got was, who is the FDA? Is it one person or a group of people? And then why are they so slow to make approval of new drugs? So that the FDA is the Food and Drug Administration for medications or other types of therapies. They generally are there for licensing the marketing of the particular therapy. So if somebody said that they had a new drug that cured Parkinson's disease, that would have to go through the FDA. The FDA would allow that licensing of that new therapy. And it's basically protecting all of you from going out and buying that thing that probably didn't work in the first place. So the FDA is there to protect people and help license things and market things the way they've been shown and proven to be marketed. The other thing they're there for is safety. So they're trying to make sure that things that go in people's bodies are safe and that they are okay for people to have. And so it takes a long time to get FDA approval and a lot of money to get FDA approval because they have a lot of hurdles and a lot of hoops that you have to jump through to get something through it. But it's there for a reason, and it's largely there to protect people. And it's also largely there to protect everybody's economic interests. So you have healthcare and a lot of things that pay for a lot of things that people use. And so you only want to use things that have been proven to work, and that's why the FDA is there.
And an important point is that the FDA does not regulate herbals and natural therapies and things that sometimes look really interesting that are over the counter. You should be aware they're not regulated. So there's a difference there in what you can know has been reliably tested sometimes.
Okay, this one is in regard to the study that Dr. Valancourt talked about, and it says, with resistance exercise, you did a 90-minute program 2 times a week per session. Can you get the same results with 30-minute blocks 3 times a day, 2 times a week? Or do you have to do the 90 minutes in one setting? I think you could definitely get the same results if you split it up into more frequent sessions and a shorter duration. And honestly, for me, there are tons of studies supporting all different types of exercise for Parkinson's. The main point of all these studies, whenever you get on a consistent program that you do multiple times a week, you're going to get better. So if you like the big program, if you like Tai Chi, if you like yoga, if you like boxing, it's whatever we can find that you will like to do, that you will do consistently, today, tomorrow, and forever, that's going to make the lasting changes.
I got a question. Could you talk about the foods and eating patterns you found most effective during your study? I know that Dr. Jakovich talked about proteins and vitamins and things like that were not as important from his standpoint, but what we found out from our study is that proteins did affect the absorption of the levodopa-carbidopa. Also, we monitored vitamins very carefully, or the specific levels, especially vitamin B6, vitamin B12, because what we found out is when their levels were very low, they were very fatigued. And I could give as much Cinemet as I needed to, but it didn't affect the outcome of the patient being less tired. So what we suggested and we monitored during our study is that instead of having 3 main meals a day, you had 6 smaller meals kind of grazing throughout the day. If you're one of the people that has to have 3 main meals, then you eat your protein, the largest part of your protein, at lunchtime. Because that way you have time to be able to process it, and then you have the rest of the evening. What I didn't talk about is that we have a bewitching hour. I don't know why we have it, but we do, between 2 and 4. Patients that seem to be on the LCIG, or the CLES as they call it now, is that they need to take a nap. They need to lay down and rest for at least a half an hour. And most of the people did not do that before, but I mandated it during the study. And what they found is that when they did lay down and rest for a half an hour, that they did have, the fatigue was gone, they were able to get going again, and it may have a combination of they just needed to rest and they needed the protein from the lunch to go out of their system. But I did encourage, and I have encouraged all my subjects, not my patients yet, but my subjects, to maintain the same program that they've been doing. The other thing that we found very interesting is that we tried at 6 o'clock in the morning with all of our subjects that they eat an orange. We tried grapefruit, orange juice, grapefruit juice, apple juice. Nothing was as effective as eating an orange to get that Cinemet going. Not sure why, there's no proof, but we know that every single one of our subjects, when they ate an orange before we put on the pump, they were much more effective. And so we should do our own little study on just the nutritional component of that. But protein does affect the Cinemet program that I'm on, and it does affect the absorption. So if you're eating pills or you're taking your pills, you're going to the gastric acid and it's competing with the protein, it does affect how it's going to be absorbed. That's my personal opinion.
Okay, so some of these are a little bit related, so I'm going to try to knock them out together. So one question was, can I take dopamine agonist and levodopa together? And the question is yes. There's a lot of patients, many of the patients in this room are on a combination of dopamine agonist and levodopa, so there's no problem with combining those, and there are clinical trials that specifically looked at the combination of those medications. In some patients, it's a good idea, and in some patients, it may not be a good idea based on age and other issues, so it really is very specific to the patient. There was another question, when will Rytary be available in the clinic? It is available now. You are able to get this medication through the clinic and through pharmacies. Rytary is the medication that was discussed a little bit earlier. I think Dr. Jankovic covered it a little bit. It's a new long-acting form of Cinemet. It's basically really small beads instead of the current long-acting form of Cinemet, which is carbidopa, levodopa with a coating on it. It is very new. It's only been out, I think it's a couple of weeks now, less than a month. So it's going to take a little bit of time to get a good idea in practice how this is really going to work. But in general, people have noticed it's been a bit more challenging than they realized with regard to making a switch to a long-acting medication like this. There are definitely going to be some patients who are not going to be able to do it, and it is definitely going to be a situation that may be very challenging. So the idea sounds great, a new formulation of long-acting Cinemet, so it does, in concept, it's a great idea, but it may be a lot more challenging, and I think that's going to be a discussion with your actual neurologist to try to implement that. And then there was one other quick question. Rytary, R-Y-T-A-R-Y. There was a question, when will doctors be telling insurance companies what will be prescribed instead of insurance companies telling doctors what will be prescribed? I would love to wait for when that will be happening also. All the issues that you all experience getting things approved through your insurance company, we're on the other side of that, fighting with the insurance companies to try to get things approved. I don't have a good answer for that, but I can say we definitely share your pain up here on the panel. There was a question about Cinemet. Has been on the market long enough to be out of patent restrictions, so why is the brand so expensive and generic pushed by the drug companies, and drug companies don't support the brand. So in general, when you're the company that has put forth the medication, the same thing as if you go to the store to buy CVS brand bandages versus Band-Aids, there's going to be a little bit of a price difference. There's a comment here, FDA only requires generic to meet 85% to 120%. So what this is referring to is if you have a medication that's on patent and it's approved, the bioavailability of that, of any generic only has to fall within about 80 to 85% to 120% range of the original. So where this becomes a major problem is if you have epilepsy. So there are some patients who can be on one brand of generic epileptic and they can switch to another brand and suddenly they have breakthrough seizures. It doesn't tend to happen as much in patients with Parkinson's disease, but every once in a while you'll get a patient who's on one brand of generic and switches to another brand, because then you could potentially be going from the 80 to 85% up to the 120% and you notice a difference. But in general, it tends not to be as much of a problem for movement disorders as it is for other types of diseases.
And tagging on the protein thing, somebody asked how many grams should I eat? It's not necessarily a particular number of grams. It's just that a heavy protein load will compete for absorption with the medicine. So truthfully, taking your medicine on an empty stomach or half an hour before your meals or 2 hours after makes it absorb more. But generally, we tell people take it with your food so you remember to take it and don't get an upset stomach. It's just if you're particularly sensitive to needing to absorb every bit of it, it can be more effective. So this question is, I have a sleeping problem, I go to sleep well and I wake up at 4 in the morning. I understand Parkinson's can cause this, what can I do? And commonly, if there's a specific time that you wake up every night at that time, there's a very good chance it relates to your medication wearing off and your body recognizing that. So sometimes we have to add a long-acting medication at bedtime to help you get through the night, or some people even will take a dose in the middle of the night. If it were less predictable that it's always 4 a.m., then sometimes it could be related to urinary tract issues, needing to use the bathroom. Sometimes it's related to sleep disorders that frequently wake people, or even anxiety. But when it's a predictable time, we always look to the duration of the medication impact.
So I'm going to talk about mood. So there's a bunch of questions I have on mood, actually, and I don't think it should take someone like Robin Williams passing away or killing himself and having Parkinson's disease to tell this audience that mood disorders are a big deal in Parkinson's disease, and pretty much all Parkinsonism. So I think we know now that up to 40%, probably more than that, of patients with Parkinson's suffer from some sort of mood disorder, whether it's anxiety, whether it's depression, depressed mood, and there are other issues obviously as well. Psychosis, kind of borders in there, so as well as a complication for Parkinson's disease, and that can be part of the disease, part of dementia, can be part of the treatment as well. So it's a bit complicated to talk about how we treat it, but I will tell you really, first for all of us, I think, if we recognize someone who presents with depression or anxiety, I'm so happy that all of you do the forms that we give you, and we're very, very appreciative that you do fill out the forms and come in. And one of the forms you fill out is two of them. One's called a BDI or Beck Depression Scale, and the other one's an anxiety scale. And we are starting to incorporate that in our clinics, so we're putting red flags on them if you really tell us you're suicidal, for instance. But the point is really, we should be asking you, if we're not asking you, make us ask you, please. This is an important issue, and all of us, I think, if we recognize depression, I find if we treat the depression first, that's really more important than treating Parkinson's. If we don't treat the depression, we're not going to really make much headway with the Parkinson's symptoms. Not only will we not have to treat the symptoms, you guys won't be able to do the exercises or want to do the exercises or therapies that are there. And the same goes with anxiety. So it's a complicated issue. There are multiple medications out there that are really good. There's a lot of antidepressants. They work for anxiety as well. There's not one good one. Someone asked about, Wellbutrin or what's called mirtazapine. It's not the only one out there. There are a number of them. If one doesn't work, we should try another one. But they generally take about 4 to 8 weeks to really have effectiveness. So it does take some time. They're not like your carbidopa, levodopa, that you take it and you know right away that it works. You have to give it some time. really get your system and change how the brain works. This is something you work with us with, and we do have two on-staff psychiatrists, Dr. Herport and Dr. Serafina, that are really wonderful. They've worked with probably many of you as well, and we will be happy to refer you to them as well. They work in the center, they work with Parkinson's disease patients or Parkinsonism patients, and they're well familiar with the issues that challenge Parkinson's patients from bottom up. Okay? So this is an important issue, and I'm really glad that someone brought it up.
So I had two questions here. It says, how do we enroll in the PD-BP or the PPMI or the UF studies if they don't have Parkinson's disease, they would like to be participating? And so in most of our studies, we do have people who do not have Parkinson's disease also in the study. So it's actually very valuable to have those people. Actually, it's actually harder for us to recruit people who don't have Parkinson's disease sometimes for our studies than people who do. So if you're interested, after we get done here, just find me and I can tell you how to contact me. If you're interested or you have a good memory, my email is vcourt, VCOURT, so vcourt@ufl.edu. You're welcome to send me an email and I can get you set up. The second one was, how do I get instructions for the resistance training exercise? I think a good way to do it would be to talk to Meredith. That would be my number one recommendation. The second one is, if you're interested and you don't go to Meredith to see her for some reason, you're welcome to email me and I will email you the program and you can take it to another physical therapist or an exercise trainer to help you get it set up. Okay?
That's a good segue into my last two, and it asks, you inform your patients regarding the UF Health and Shands Fitness and Wellness Center on 13th Street. Wouldn't this be a great resource for your patients? Absolutely. So when I sit down and talk to the patients, we go over all of the options. The Shands UF Health Wellness program is wonderful. They have trained exercise physiologists on the premises that will help you get on your machines, get off your machines. But one of the things that I consider, are you still driving? Can you afford it? Being on a fixed income can limit access to working out in some of the gyms around town. The other resource that I know a lot of you all partake in, the senior center has access to equipment at a very low rate. They also have two ongoing exercise classes specifically for patients with Parkinson's. So there are a lot of resources in the community, and for me, instead of just telling everybody this is the best place to go, it's good to sit down and find out what's going to be the best place for you to go based on all of the different factors that are going on in your life. Is there a metronome app for the phone? Absolutely. If you just go into the search query and type in metronome, there are probably about 12 free ones that will pop up. And like I said, 80 beats per minute would be the cadence to try.
Okay, we'll do just maybe 2 or 3 more, and then if you didn't have your question answered, you can grab one of us afterwards. We'd be happy to answer it. One of them here is a good question. It says, recently I've had to reduce my blood pressure medication because my doses. What should I do if this is because of my Parkinson's medication? So it's a good question. There are some of the Parkinson medications can lower the blood pressure. If it's a mild effect, you may be able to work with your primary doctor to be sure it's safe, and then you may be able to lower your blood pressure medication. The effect is not always that strong that you will come off or lower it, but be careful because sometimes your blood pressure pills also may be used for your heart or for some other reason. Parkinson's itself can affect part of our nervous system called our autonomic nervous system. And it's the part of us that regulates stuff, and it moves our guts, and it controls our temperature regulation, and it controls our blood pressure. And sometimes people can have a problem where their blood pressure goes super high and super low, all within hours, all within even less than hours, and that can be trickier to manage. But if it is your Parkinson medication, the first question is there an alternative? Because sometimes we can make changes in the medicine and have less of an impact on the blood pressure. And the other question is, do you just have to be on that? So sometimes it might be that there's no choice, you need that to function, in which case there has to be a balancing with the blood pressure medicine. I'll do this last one in front of me, and then if you have another one. And this is, what effect does general anesthesia have on Parkinson's disease? And it's a good question because we don't fully know the answer, but what we do know, first of all, there are some Parkinson medications like selegiline and rasagiline that may interact with certain anesthetics, and those would need to be held for a week before surgery, or your anesthesiologist would need to know you were on them. But anesthesia itself, we know that in some individuals who may be vulnerable could potentially cause a setback. Sometimes it's a cognitive setback, meaning memory trouble, and sometimes it doesn't. Most often people don't notice any major changes, but because we've recognized that we sometimes see that, we've actually had our neuropsychologist, Kate Price, is very interested in this and actually will do detailed testing with people before they go through an elective surgery, and that might help them decide if their cognition is doing pretty well and they have a little bit of reserve, they might decide to take a risk on a surgery that's not necessary. Now, if you have a necessary surgery, then you have to do it. There's no choice. But otherwise, we can do testing before and after, and it can help you make an informed decision.
So I didn't mention there was one question about emotions going up and down. I guess if you have that, I didn't mention that one, but if you do have problems with laughing or crying, that's sort of inappropriate. In other words, you're laughing, where you may see like something that seems kind of innocuous, but your spouse or your loved one actually is laughing kind of inappropriately. Or, for instance, if they are crying uncontrollably, and it's, they may be telling you, I'm not really sad, I'm just crying because I can't help myself doing it. That's what we call a labile mood. There's another term that we often use called pseudobulbar affect. So this is another very trying symptom in Parkinson's, and typically not Parkinson's disease, but other atypical Parkinson's disorders. There is treatment for it. It's actually kind of called cough syrup plus a quinine or quinidine type mixture. And there's a drug called dazed that's out that can actually help. But generally speaking, we treat also with antidepressants. If this happens, let us know. There are ways to actually effectively treat it. I have one more actually too, and I'll address this as well. So people are asking about this alpha-synuclein protein. So I think you heard that Dr. Mankiewicz this morning actually bring up that there are a couple of hallmarks to Parkinson's disease in the way we diagnose it. One, of course, is the loss of dopamine cells. And then at a microscopic level, we see accumulation of proteins in the brain. This is actually fairly common in almost every degenerative disease that we see. Parkinson's disease, Alzheimer's disease, frontotemporal dementia, ALS. They have a very common sort of hallmark that we see is abnormal deposition of certain proteins. In Parkinson's disease, it's these Lewy bodies, and they contain a lot of protein. That protein frequently is called alpha-synuclein. So someone asked me, what is it? Well, alpha-synuclein is actually a normal protein, just like in Alzheimer's disease. Amyloid is actually a normal protein in your brain. It's actually when it goes awry, either misfolds or starts to accumulate in an abnormal way. So we're really talking about normal proteins in your brain that basically either accumulate or they get tagged some way or they basically start to act in a wrong way. And they accumulate and they get in the brain and they form these things called Lewy bodies. So you can imagine if a cell basically gets filled with a giant protein and it forms this large inclusion. It's not a good thing for your cells. Your cells don't work properly. And in fact, it actually causes stress in the cells and the cells begin to die. So there's a lot of research, our lab and many other labs around the country and the world are actually trying to figure out what that cascade is, what makes alpha-synuclein aggregate and form these Lewy bodies. So there's a lot of work ongoing. And there is good data now suggesting that synuclein, when it goes awry, it does cause degeneration. And so a lot of people are focusing on it. So you heard this morning there are new treatments potentially coming out. So antibody treatments, there may be other ways of going about it as well to target synuclein. And I think someone asked a really good question is like, so what if we have these treatments? When are they going to be good? Are they going to help me? So I think whoever asked that question was actually, it was a really good, brilliant question, actually. So these treatments are going to be focusing on the cause of Parkinson's disease, and it may be true that once we see patients, largely we see patients, we say that by the time you're in our clinics, you've lost about 70-80% of your dopamine cells, and likely due to these proteins that are accumulating in the brain. So we do need to identify patients earlier, and likely if we do have these new treatments, we're going to be targeting earlier patients. That's not to say that there may be some benefits for patients who have Parkinson's disease now. But I think it's definitely, there's a lot of hope here for these new treatments. And we'll have to see how they actually turn out. But I think we're working towards these. I think you heard Dr. David Valford talk about biomarkers. We heard Dr. Jenkins talk about biomarkers, finding markers either in blood, fluid, tissue, or even using the brain imaging that Dr. Valford talked about to really diagnose patients early in that pre-symptomatic phase. That's where things are heading in the future. So it's really important that you all participate in our trials. We're learning a lot, and I agree that the research that we're doing now may help future generations, but this is really key. I think we want to help the future generation. And this is where the new treatments, and I hate to say the word cure is, but if we could stop the progression of disease, and mild tremor is a heck of a lot better than needing a wheelchair. I think there's a lot of hope, but that's where the importance of getting these markers. I mean, your studies too, how biomarkers are needed.
Yeah, I mean, it's all about the future. It's about the way the future, different therapies are going to be tested in the future. And so it's difficult to say that it will help people now because it probably won't. But it's going to help. It's going to help your kids. It's going to help your grandkids. It's going to help your cousin. And it's going to help people like that. It may help some of us on stage. Yeah.
So thank you so much for coming and for giving us great questions. And please let us know if there are topics you want to hear about next year. Every year we're trying to decide what we could have spoken about that you wanted to hear about. This is Amanda, and we're grateful that she organized this for us and found a facility and made it all happen. So please feel free to tell her or any of us topics you want to hear about or questions you didn't have answered, and we hope to see you again. Thanks for coming.